Okay, welcome back to part 2 of 2 on focal nodular hyperplasia. In part 1, I discussed some of the key imaging features of FNH, the central scar, the feeding vessel, the enhancement, the washout like the IVC, the fact most lesions are solitary, 8-to-1 female over male, no malignant potential. Now let's do a little bit more where the cases are maybe a bit more challenging. And then I want to show you some ideas and an article I literally read within the last 2 days, and I'm talking about the end of January when I'm recording this, and share it with you. Now, first of all, here's another lesion. You can see it's next to the IVC, almost looks like the IVC on the arterial phase imaging. Okay. And then you keep scanning, it looks like FNH, but wait. There's a lesion in the liver here and a lesion in the pancreas right there. What is that? It's a younger female. It's a lesion. When you look at the liver lesion, let's look at that alone. It's very bright. There's no cirrhosis. There's a second small lesion probably next to it. It's nice arterial phase. It's enhancing like the IVC, but you have the pancreas lesion. When you have a pancreas lesion, what could this be? Well, it doesn't look like a neuroendocrine tumor, which are typically vascular. It looks like a low-density lesion. So now I'm dealing with a pancreatic lesion. If the patient was 40 or 50, I would say this could be a MCN. And if the patient's 20, I would say this could be a SPEN. But there are other possibilities. There's no dilated pancreatic duct. If you look now going back at the liver lesion is isodense, and the pancreatic lesion is still there. It's hypodense. There's no dilated pancreatic duct, but the lesion is well defined. This lesion was eventually taken out. Here it is beautifully on the cinematic rendering. You can see the lesion really standing out. Beautiful look at the celiac and SMA. There's no evidence of vascular invasion. So what are we talking about? Liver mass, pancreatic mass. Liver mass looks just like FNH. Pancreas mass, I mentioned some of the possibilities. This patient did have a biopsy, and this was a SPEN tumor. Again, you have to think about that obviously if you have a pancreatic mass and you're worried about malignancy, SPENs over 90% will be cured with resection. But again, you always think about, could this be a liver mass? And it is a liver mass, of course, but not malignant. And so it's FNH. Nice diagnosis. Here's a patient with renal cell carcinoma, and you have a big liver lesion, left lobe of liver. Big central scar, feeding vessel. Could this be metastatic renal cell cancer? Clear cell renal cell cancers are often vascular, and they do go to liver, but they're usually brighter than this, and then you have that central scar. When you look at the MIP imaging, you can see the vasculature is stretched with a little bit of feeding vessel centrally toward that scar. But again, could this be a metastasis? Could this be hepatoma? Could this be FNH? Well, the lesion behaves. It becomes nearly isodense with some scarring on the late phase imaging. You can see on venous, it's stretched, some of the vessels, very much like a couple cases I showed you previously with that central scar. Displaces vessels. Now, if this was hepatoma, it would encase vessels, not simply nicely displace them. If this was metastasis, it would likely have neovascularity and encase, not displace. A few more images of that. And it's just a wonderful case. This was FNH in a patient with renal cell carcinoma. Now, eventually in this patient, they did an MR. They were going to do a biopsy, but we had old scans, and that was present before. But you could see it can be challenging. But here we go, 1, 2, 3 on that lesion. We go from very bright to displacing vessels, but nearly isodense with central scar. And on later phase, it even becomes almost more isodense. So again, FNH as an incidental finding on a normal study is much easier than FNH in a patient like I showed you with a pancreatic mass, or a patient where you have a renal cell carcinoma by history. We are always worrying about metastasis. So again, you need to have some conviction and recognize your limitations, but also don't assume everything in every patient with a tumor is going to be malignant. Now, you can see multiple lesions at the same time. We mentioned 10% or so of FNHs have multiple FNHs, but this is a case of a nice example of a hemangioma in the left lobe of the liver. And then we talk about the patient having FNH plus hemangioma, nice feeding vessels. So again, you can see multiple different lesions. You can see the lesion has a scar, becomes isodense. Another example where the patient has a FNH and two examples of hemangiomas. But the hemangioma, look at the left lobe, the large lesion, classic puddling. Look at the FNH, classic central scar that's present right there. So they look different. But again, something, I go back, show it to you again, to remind you, you can have concurrent liver lesions. Here's that same FNH, very nicely shown on the cinematic rendering. So I think one of the things to remember is you can have FNHs, which are benign lesions, in patients with malignancies. You can have FNHs with other lesions in the liver. So I've seen one case of FNH in fibrolamellar I've seen many cases of FNH in hemangiomas. I don't think I've seen a case of FNH in hepatic adenoma. Here's just another example, right lobe of the liver, vascular lesion, FNH, big hemangioma with classic puddling in the left lobe of the liver. Here's a nice example. We mentioned that pedunculated lesions. You can see that's a pedunculated lesion. I remember doing this case. I didn't know what it was. It was sent in for hepatoma, but the liver wasn't cirrhotic. The lesion's a bit denser. When you look at it a bit more carefully, it becomes isodense with time. There was a small vessel present. This is pedunculated, and this ended up being FNH. Okay, there's the feeding vessel. A very challenging case, but again, pedunculated lesions, and we are putting together an article with Philippe Sayeri from France about that, trying to see if pedunculation is critical in terms of being specific. Most of the time it's FNH and hepatic adenoma. I've seen hemangioma. I've also seen malignancy, but most of the time it's benign, and there's some of the feeding vessel going to that FNH. Now we talk about feeding vessels. I always like to show this case. It's an older case, but one of my favorite. This was a Hopkins house staff who had a palpable mass in the right lower quadrant. And this mass, at first guess, maybe it's not the liver, but this was coming off the right lobe of the liver. I'll show you. And then you have the patient's hepatic artery and a large feeding vessel into that lesion. And that lesion was coming off the liver. We talk about CT angiography with feeding vessels in FNH and its importance. Again, this lesion was kind of a really interesting lesion, but ended up being FNH. Now, in terms of going forward, I mentioned to you that I was reading something, and this article, Focal Liver Lesion Diagnosis with Deep Learning and Multistage CT, that was recently published. And this is some work out of China looking at how well you could do distinguishing between hepatoma, intrahepatic cholangiocarcinoma, metastasis, FNH, hemangioma, and cyst. And they said their program demonstrated a diagnostic accuracy of 91% for distinguishing between benign and malignant tumors, 82% for distinguishing between malignant tumors, and 92% for distinguishing between benign tumors. And compared to junior radiologists, it was better. Okay? So this is some preliminary work, but they did show that with junior radiologists especially, but even more middle-level radiologists, and even senior radiologists. It was helpful in diagnosing benign tumors like FNH. This LILNet, which is what they called it, outperformed junior-level practitioners by 20%, mid-level practitioners by 10%, and senior practitioners by 6.7%. So the usual thing they'll mention is perhaps this might be helpful, particularly in environments with less quality radiologists, or everyone's really busy, or just perhaps it should be something that's done routinely. Here's a little bit more of their results. And again, this idea about the partnership between AI-assisted software and radiologists holds promise for enhancing the accuracy of liver disease detection. And we're doing a lot of work with AI of pancreatic cancer. I saw an article yesterday on AI for early gastric cancer. Here we're talking about liver lesions. You could see slowly but surely, and there's a long way to go, we are building up the possibility of being able to look at the entire abdomen and detect significant disease, particularly in the solid organs. So let's summarize a little bit. FNH, classic in the liver enhancement, but can be one of the things that's pedunculated. Okay, so just think about that. We talk about its enhancement pattern. We talk about the fact that FNH, whether you're at 16 slides, 32, 64, 128, 256, it's bright early phase, central scar, feeding vessel. It's only as bright as the IVC. We talk about how it becomes isodense over time. We talk about the feeding vessel. We talk about displacement of veins. We talk about how it becomes isodense over time. So just to show you, to come back to the beginning, vascular lesion right lobe is gone. That's FNH. Vascular lesion right lobe of the liver, nicely seen. Not quite as bright as the other study, but there it is again. Isodense is gone, FNH. Or this larger, very bright lesion, but only as bright as the IVC. Central scar, feeding vessel, and then as we go forward, the lesion becomes nearly isodense, but you still can see it. So going back to Google, going back to Gemini, key features: central scar, feeding artery, sharp margins, unencapsulated, but almost looks encapsulated, absence of atypical features, no fat, no calcification, no necrosis, no hemorrhage. And again, it does have atypical appearances. It can be somewhat challenging, is usually solitary, but can be multiple. But I think once you learn and see a lot of cases like we did today, I think you're going to be able to think about it better. What if you can't come up with a diagnosis? MR can be very helpful in those scenarios. And again, the importance of protocol, non-contrast arterial and delayed imaging all allows you to better understand the lesion. And that's going to be true with any lesion in the liver. Multi-phase imaging is critical to define hepatic adenoma, detect hepatoma, define FNH. And with that, I hope this has been helpful. And have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.